very good evening to you out there who is watching UBC TV. Thank you for staying with us from the 8 o'clock bulletin right up to now. My name is Sophia Matovo and you're watching U Health Chat. Now, Uganda has significantly reduced rates of mother-to-child transmission of HIV/AIDS, which is a very good thing for us. However, there is an increasing HIV prevalence amongst the adolescents and worse when it comes to the girl child. Since I'm not the expert on these matters, in studio to share on the topic of discussion is Dr. Nelson Musoba, the Director General of Uganda AIDS Commission. Good evening, Doctor.
Good evening, Sophia.
How are you?
I'm fine, thank you.
Thank you for taking time off your busy schedule to come through for the show.
It's a pleasure. It's a pleasure. Thank you for inviting me.
Okay.
Yes.
Now, before we dig deep into the topic of discussion, I'd like us to take a look at one of the stories that was done by UBC. Yeah, and this story still is in line with the topic of discussion that we are going to be sharing, and then we can go dive straight into the topic. But first, the story.
Out there somewhere, alone and frightened. Oh, the darkness, the days are long. Life been hiding, now I'm making new contact. No more loving arms.
People have moved from stigmatizing people with AIDS to stigmatizing the AIDS response.
It is now 41 years since the first Ugandan was diagnosed with human immune deficiency virus, HIV, and acquired immune deficiency syndrome, AIDS, in 1982 at Kasensero landing site on Lake Victoria.
The struggle has been challenging, as all struggles are, but because God is with us in the struggle, we have experienced love and grace that we need to do this work. Now I am counting my 31st year of doing this ministry, and we've seen a lot of miracles and breakthroughs along the way.
Some people started calling me the living Rutare, and I have lived that long. I was 57. I was 37 when I got HIV. I'm now 75. So really, I think that alone makes me happy.
HIV is about to go. As women, we are committed to ending AIDS by 2030 because we have the tools, we have the resources, we have the expertise, and we are motivated to do that. All we need is everybody to join us in the movement that we have created so that we are able to get where we need to get.
Tested HIV in 1997. Was living outside, came back to Uganda, found a country which was really doing well. Actually, Uganda is one of those icon countries where fighting stigma, fighting the epidemic started many years ago, and we are very proud of our own country.
There were a number of interventions globally which saw Uganda bring down the HIV prevalence from over 13% to about 5.5% nationally. According to renowned HIV and AIDS activist and Director of Health and Community Outreaches in Operation Wealth Creation, Major Retired Rabaramira Ruranga, the current HIV prevalence among the youth population is worrying.
Actually, very, very much disappointed because I thought by this time nobody would be getting infected with HIV. But I'm still seeing so many numbers. We are 1.4 million people who are living with HIV, and many, especially ladies, are getting infected every day. And I am wondering what has happened or what has not happened.
Another HIV and AIDS activist and first religious leader to declare his HIV status in Uganda, Dr. Gideon Byamukesha, is equally worried that HIV and AIDS stigma is failing all the efforts they had set to end HIV by 2030.
The stagnancy that we are experiencing is being caused by inequalities of access. Once we have the science, we have everything, now we are remaining with how come that some people access medicine, others don't? How come that some people access love and grace and support from their faith communities and others don't? What is the criteria that people use to give me, like me? I've been loved and supported and gracious, but there are people like me who are positive and struggling. So akasengeja, where do people put the line and say ono tumwagale, ono tetumwagala? You know, so we have that inequality of access to 3 areas. One is the youth empowerment, skilling, and accompaniment. And the Bible says, train a child the way they should go, and you will sure they will never depart. But we have so many young people, they are not in education, they are not in employment, they are not in training. How is that young person going to protect themselves from HIV? And if they are already positive, how are they going to prevent transmitting the virus to others? So that's one critical area that people are interested in fighting AIDS and winning should look at. Number 2 is inequalities around safe behaviors and practices. There are people whose daily life make it sure that when they want to choose the safe behavior, they choose the unsafe one. The unsafe ones are the easiest, they are the popular, and they are almost the routine. While the unsafe ones are rare, they are not even popular, and you can't choose them because of the type of life you are leading. No employment, you are in slum areas, the men are pressurizing you, no one is talking about male power. So you are in that situation where you can't do otherwise than transmit or get the virus. So people have to look at that. Access to treatment. We have 200,000 people, they are positive, they are not in treatment. Where are they? Why are they not on treatment? What is happening to their life? And there's those who are on treatment because of the stigma and the discrimination that still exists. They cannot adhere on treatment. So we could really do better if we focus on those 3 areas.
HIV/AIDS prevalence, according to UNAIDS data, is rising exponentially among adolescent girls and women than men. Lilian Moreko is the convener of the East African Fierce Awards and founding member of the International Community of Women Living with HIV East Africa.
HIV still has a female face, and now the face is strange that we are talking about a face of an adolescent girl and young woman. That in Uganda, for example, 570.
Well, as you can see, that story was run in the UBC News some time back, just this very month, so it clearly indicates we have a problem. But I'll first get straight away to Dr. Nelson Musoba. Now, if we say that HIV is shooting high amongst the adolescents, what were the percentages back then and what are the percentages right now? And how fast is it really like gone up within this span of time?
So, first of all, as a country, we've done well in terms of progress. You know, we've moved, as you were hearing in the story, it's 41 years now since the first AIDS case was diagnosed in Uganda. And back then, the HIV prevalence in the general population was an average of 18%. But in specific subpopulation groups, it could go as high as 30 or even 40%. Now, we are talking about a prevalence of 5.5% currently. But new infections still remain high. So it means that while the people who are diagnosed positive are started on treatment, as you heard the Reverend speak in that story, there is a group that is not yet, you know, they are positive. Either they don't know that they are positive, and if they are adults and they continue to engage into sexual interaction with their partners, they pass on the infection. Or because of stigma, they have not yet started on treatment, but still, you know, they continue to pass on the infection. So new infections, like in the last year, we had 52,000 new infections in 1 year. And once you do that, and a large proportion of those are amongst young people between 15 to 24. And even within that age category of young people with new infections, 4 out of every 5 young people who got a new infection was a girl. So the girl child is even more disadvantaged. And it is really the inequalities that we are talking about. You know, they have low bargaining power, they have no knowledge, you know, no skills to, first of all, comprehensively differentiate and be empowered to avoid risk behaviors. They are the ones who are prone to either they have multiple partners, they're engaged with partners who are older than them, who are giving them money, and they get disadvantaged in terms of negotiating for safer sex. Many times they will engage in sex without, you know, using a condom, or they don't know the sexual status of their partner or even themselves. So that is one aspect around knowledge, awareness. But there are also structural factors of household income and wealth, because if a household is disadvantaged, you know, they have 5, 6, 10 people in the house, they'll look at, you know, this 15-year-old girl, and you know, the household is really pressured because of poverty, and every extra person they can push out, they'll do that. So early childhood marriages are one of the factors. So income inequality and poverty are another key factor. Behavior is another one, but cultural practices, you know, such as early marriages, transgenerational sex, inheritance. You know, when a woman has lost a spouse, they say wealth shouldn't leave the family, and one of the family members, without knowing what the cause of death was.
They send them into that
so
marriage.
all those factors at individual level, at household level, and at community level predispose the women. And for young girls specifically, we now have what we call the triple threat of new infections, of teenage pregnancies. We saw during COVID, you know, that because the children were at home, we always thought that home is a safe space, but COVID proved us wrong. You know, school now, you know, turns out to be one of the safe spaces where you should. So the longer, one of the interventions that we need to have is that to make sure children of school going age, the longer they stay in school, the safer they are. In terms of protecting them and ensuring that, you know, you keep them away from new HIV infections.
What happened to the ABC strategy? Because I remember the time, I think, when we were really excelling as a country, it was like a song. You found posters, you found messages. It is, but now it's like, it's normal. It's like people probably even maybe where you're getting the many high rate of infection among the young adolescents, and particularly the girls, is maybe they think it's one thing that died out, and they probably think it was for those days and it's not there anymore.
That is true, and that's a correct observation, that the ABC campaign worked for us as a country. I was talking about the double-digit HIV prevalence rates in the 90s. We were able, the first 10 years as a country, with our leadership, you know, the president, the first lady, and the rest of government leading, we were able to reduce HIV prevalence from 18% to about 6.4%. At the time, very few of our people had access to antiretroviral therapy because the drugs were expensive, they were not accessible, because ARVs became accessible on large scale from 2004-05. But abstinence, being faithful, and condom use were the mainstay. So, you know, every time you discover a solution, there is a side you should always look at. So when treatment came, and you know, people, when they take it, they look normal, a lot of the stigma went, a lot of the fear factor went, and there was complacency. And as we focused too much, so we've just, you know, started implementing what is known as the HIV combination prevention method. It means that you focus both on communication as well as treatment, because treatment, first of all, by itself is a prevention method. If you take your treatment well and your viral load is controlled, then you'll not transmit, you know, the HIV virus to your partner. But that means also the other factors of, you know, abstain until you are of age, you know, until you're ready for the consequences. So that campaign, we've, you know, rejuvenated it. We are working with the school children, the young people, to ensure that they focus on the A especially, and the purity campaign. There is real value in that. It's only those who can't do that, who, you know, either by accident or what, they have become pregnant, but they still, the Ministry of Education has a policy of second chance. You know, the children can still go back and be given after giving birth and be given an opportunity. But the ABC is now, should become one of our mainstays. If we don't, it will be difficult to close the tap on the 52,000 new infections that I've spoken about.
Then talking about some of the infections, I believe there are some of those who are children that were born with it.
Yes.
And naturally, and sometimes parents will still shield them and will not tell the child while they are going through the whole treatment process that they are going through, why they must take the medications that they're taking, because they are afraid of how do I break the news to this child that they're HIV positive. Now this child is growing up, he's an adolescent, going into the stage of being a youth, and they need to have a life. Could that also be one of the factors that is leading to the rise?
Yes, that's a major problem, because, and we had done good work, as you mentioned when you're introducing the program, that on the prevention of mother to child, there's a time really we were on the verge, because up to now, one of the areas that we are doing very well is when mothers get pregnant and they go to a health facility, there's a provider-initiated testing and counseling, you know. So it means that every mother who attends a health facility gets tested. So because of that, over 95% of our mothers who have been pregnant know their HIV status. But still, there's that small fraction, mothers who don't maintain the treatment, you know, visiting the facilities, or who don't deliver in the health facilities. The babies end up acquiring HIV. So that number is still there. In fact, last year we had about 6,000 babies who were born of HIV positive mothers who became HIV positive. So these children, when they grow up, the mother can work with health workers to ensure that at the right time you disclose the information appropriately. It's not right to keep this information away from them, because it causes adherence issues. If the child doesn't know why they are taking treatment, later on when they know it, it will be very difficult. They will, you know, they will have issues, not just with themselves, but even with you as a parent, and they may blame you for this. So it's important, as early as possible at an appropriate age, you can be supported by a counselor and a health professional to disclose this to the child. And it is recommended that, you know, a necessary support group is created around these children, because other than homes, the other place where stigma and discrimination is occurring is, for instance, in the school environment.
Oh, yes, yes.
In schools, either by their peers or by their teachers, when you listen to the stories and testimonies. So, Uganda AIDS Commission, working with the Ministry of Health and the Ministry of Education, tries, you know, to raise awareness, to train teachers, to ensure that we need to have a mechanism to protect these children, to not stigmatize them, because we know that if you take your treatment and take it well, these children grow into productive adults. We have lawyers, we have doctors, you know, who are living with HIV but are quite productive. So it's possible to guide them and support them into becoming productive adults when we do the right thing.
Okay, that's interesting. Then what about the fact that this is a fact? I've done my research on it. You'll find that these young girls still are more worried about getting pregnant. And they'll try to take all precautions after they have had unprotected sex. But HIV/AIDS, no. What is the strategy to protect them?
So first of all, that is another problem with the misinformation, because we need, with these children, we need to start early. There is what they call age-appropriate sexuality education. You know, you start when the children are asking questions, give them, and studies show that the best source of information for a child from as early as, you know, 3, 5, by the age of 8, before 10 years of age, should come from the parent. Okay. Because children will always believe the first source of their information. Now, when you delay to disclose the correct information to them, They will listen to what their peers are saying, and often this information is half correct. And part of the myth is that one. The young people need to be told that HIV still has no cure, that it has no vaccine, and that although there is treatment, when you're diagnosed HIV positive, you'll have to take your treatment for life. It means every single day you'll get up, swallow the medication, you have to go for tests. It's not an easy thing. So any young person out there talking about, I would rather have HIV than be pregnant, do not know what they are talking about. Of course, you don't want to get both of them. A young person should neither get pregnant nor have HIV. They should wait, for the right time, and they should protect themselves as much as possible. Yes.
Now, from the story that we ran, what about the issue of access to drugs and medications? Are there any limitations that, there is some kind of like this ones can easily access while the others can't? What's the criteria like?
So what you're hearing about access is largely a question of stigma. Over the last several years, both government and partners have worked such that we have sufficient funding, especially coming from our partners, but government is contributing as well to have the medicines that are required. Of course, we have, first of all, when you're diagnosed HIV positive, you're started on treatment immediately, and you're started on what is known as first-line treatment. More than 99% of all our patients are on first-line treatment. Now, if for some reason that is interrupted, and you'll become resistant and go to second line. So out of approximately 1.3 million people who are on treatment, 54,000 are on second line.
Okay.
Now, should problems occur again, resistance can develop and you go on third line. Now we have about 2,000 patients who are on third line treatment. Now every time you change a line, it is more complicated, it has more side effects, you require more specialized care to have that treatment. So it means you will move longer distances. So when you're on third line, it's unlikely that your nearest health facility may not have it.
Okay.
So that is one. But two, the way our health system is structured is that we've not fully differentiated, and created spaces for young people. So often when a young person comes, it is the same pharmacy, it's the same outpatient. There's an attempt to have an adolescent corner, but very often you're moving with adults. And, the young people will not feel uncomfortable. They will not wait long in the line. The adults are looking at them. What is this young girl doing in the HIV line? How did you get this? So because of stigma and discrimination, they will again keep away. And they need they need us to differentiate a service to ensure that either we are creating a corner, or we are having a special hour, or we have a fast track for them. So that so those are the access issues that that the team was talking about. They largely arise from stigma and discrimination.
Okay. Now, this year during the Candlelight Memorial, it's a day that I know, Uganda AIDS Commission does have on their calendar. I saw it take a different turn. Previously, years back, some of these events, the ones where you'd hold in form of a conference, and it is the adults like me and you who are there. But this time around, you did something a little bit different, where you went to Kitante, the school. Why did it turn out that way?
We've, as Uganda AIDS Commission, working with our partners, we've taken a deliberate step to change strategy, to move closer to the people where they are. Even before the Candlelight, we had the HIV Symposium where we went to Makerere Business School. We made it open air. Everyone would come and access. There were stalls. You can ask questions. We still put a room aside for scientists to share the papers, the science, and the research. But there was no restriction. And the purpose was really to ensure that, because the studies, the innovations, the information is for the population. So during the Candlelight is one of those days where we do advocacy, we raise awareness. It is a commemoration of those who have been affected and impacted by HIV. So yes, like you noted, we said we are going to work with young people. We chose a location which was a primary school. We involved the leadership of Kitante Primary School. We had the young pupils acting in a play. We had a debate. between St. Mary's College Kisubi and Green Hill Academy, debating about HIV and how to deal with it. And it was very interesting because we've learned that to be able to communicate a message, you need to communicate through young people. Young people have a unique way they communicate. They want to listen to each other. They're unlikely to listen to the adults. They use a very specific type of lingo. And that is why, you know, we've chosen to do that, and I will continue. There are countrywide debates that are happening now in secondary schools, you know, around HIV and AIDS, and the purpose is just to raise awareness, but through young people engaging each other. And for us, we can come in, we can support, we can make sure that, you know, the debates are appropriate, they are given information, and they are supported, so that we continue to skill them and support them to protect themselves.
Okay. What strategies do you as Uganda AIDS Commission have in place to see that there is an improved, you know, identification strategy of identifying, because certain times some of the adults might not disclose that they are HIV positive and they'll take advantage of these young adolescent girls. Do you have any kind of community testing strategies in place to make sure that somebody can, you know, be able to easily access and know? Because why I'm asking that, we've had scenarios of where you know that somebody can easily go and buy a testing kit and they'll tell you I have tested, and they'll possibly even decide to tell you that, you know what, it is that way, or it's the other way. Or if they take advantage of this young naive girl who cannot tell that if the strip has 2 lines, it's a sign that somebody's positive. How and what strategy do you have in place?
Yeah, so again, we've designed strategies, especially focusing on young people at 3 different levels. There are strategies looking at the individual, and for the individual, we make sure to say, do they have enough information about what are the risk factors? You know, we educate them, we tell them that, first of all, having a sexual relationship with somebody whose HIV status you don't know is a risk factor. Having sexual relationships with multiple partners is a risk factor. Having sexual relationships with older persons is a risk factor because they have higher bargaining power. Having sexual relationships with people who have given you money is a huge risk factor because, again, it is, you know, a power imbalance. So at individual level, those are factors, but there are those you target households and ensure, you know, to make sure that for children of school-going age, they should be in school because we know school is a protective space. But also government has several interventions to ensure that household incomes, you know, are also getting protected, because you can give a young person knowledge, you can give them information, but if they can't put food on their plates, if you don't support, you know, the wealth inequality, then it becomes difficult to protect them. So there is the household level, through initiatives like Operation Wealth Creation, the Parish Development Model, the Youth Livelihood Program, the Women Empowerment Programs, that households are protected. But there are also interventions targeting communities, including stigma, discrimination, training them. So that's on one aspect. But in terms of access, there's also ensuring that, you know, services like self-testing are put in place, that, you know, if somebody wants to know their HIV status and they can't stand going into a long line, they, for some reason, again, they are feeling stigmatized, there's that option of going to a pharmacy, getting a test, knowing their status, and there are very clear instructions on, depending on the outcome of the test, how you then go ahead and get that confirmed. So there are different strategies, and we're working with the Ministry of Health to ensure that all these, the young people can access them and as much as possible get protected from getting new infections.
I can see you trying to cover up, or to make sure the young people are treading the safe line. Then where do the parents come in to support? Because given the generation that we have right now, most of the kids are growing under the care of the house helps. Truthfully, the parents claim economy, they're looking for money, they're trying to see to it. Don't you see, I need to work so hard to get your school fees. They have all sorts of excuses to stay away from these young adolescents.
Now, the parents have a huge responsibility to play, because like I said earlier on, the parents should ensure that they are the first source of information about sexuality, and ensuring that their children are fully informed, that they know what's, you know, the bad touches, the safe things, avoiding, risk situations, and they can, but also build the confidence. So parents need to be close to their children. They should have children confiding in them, come to them. If a child has been either assaulted or, inappropriately touched, you should be close enough to your child to come and tell you, Mommy, Daddy, this is what happened, and then you can intervene immediately, because sometimes it's done by close relatives. People who are known to them are the ones who are abusing these children. So parents have a lot of responsibility. I know that we have to run out for livelihoods, we have to be working, but at the end of the day, if we make all this money and we lose our children, they become HIV positive, then you'll sit and look back and say this would not have happened. We shouldn't leave these responsibilities to only the teachers. The teachers can pick up, but only from where, we've started and ended.
Doctor, so among the different communities and strategies and everything you've put in place, what are some of the worst case scenarios? Because now we also know the fishing communities are highly highlighted as one of those areas where, I don't know, is it because they're isolated on an island where HIV is highest? I beg for you to throw
So
shed
we
more
have what we've grouped together and called vulnerable populations. So the 5.4% HIV prevalence is the average, but there are population groups who, because of their behavior and especially risk behavior, the HIV prevalence is much higher than the general population. This include the commercial sex workers, the women who, the HIV prevalence is as high as 20%. It's quite high, between 20 and 30%. The fisher folks, like you've mentioned, they are young people. They have survived, the risks of the lakes and the waves. They have money in their pockets. The HIV prevalence is much higher than the general population. The people who inject drugs, because they are sharing needles, but they are on drugs, their judgment and the HIV prevalence is much higher. The men who are having sex with men. And a number of these groups under our Ugandan laws criminalized, so they tend to go underground in terms of access, and yet from the public health side, these groups also interact with the normal population, because either the commercial sex workers, the fisher folks, also, so when the infection is higher amongst the vulnerable groups, it could easily cross even to, a normal couple in a relationship. So those are the categories. The armed forces, incarcerated populations within prisons, the HIV prevalence is much higher. So there are settings that make certain population groups have a higher HIV prevalence than the rest of the population, and those are some of them. And there are efforts designed by the Ministry of Health to ensure that services are specifically, it's called the differentiated service delivery model. It means the health workers don't just sit in the clinics and wait for them to come. They'll make sure that they have outreaches, they do testing services, working with the NGOs. You'll find testing services being done at night, condom distribution being done at night, because if we sit in the health facilities and wait for them, they will not come. They will not come. They know they are stigmatized, but also for some of them, like the sex workers, it is the time they are out there applying their trade.
Yes, true.
Yeah, so there's a very specific intervention and arrangements to ensure, because if we do not have this group covered, then we will never bring new infections down. Yeah, it will just, it's like, you're mopping a floor, but the tap is open and the water keeps
continues flowing.
Yes.
But can you say that with that intervention on the high risk groups, that government is doing well, the response in terms of their adhering, and they know that, oh yes, like the commercial sex workers, I'll just give an example, and they really are receptive to use the condoms? Because there's some of them, you hear stories and they'll tell you that with the condom, the pay is this much. When you have unprotected sex, the pay is that high. Yes.
So with continuous education, a lot of them will protect themselves, but again, there is that complacency. There is that complacency. So one needs to protect, to target both sides, that you're targeting those, the women of the night, you're giving them the condoms, you've given them education, they're accessing testing services. The other intervention is pre-exposure prophylaxis. If somebody is at very high risk and they can easily get infected. Then you give them a pill that they take continuously so that if they get the virus, then it will just be killed. Also, couples who are discordant, if one couple is positive and the other one is negative, then they qualify, the negative partner qualifies for getting pre-exposure prophylaxis. So with that level of intervention, yes, there are those who will take the risks, but continuously engaging and interacting with them and saying you need to be alive, because many of them, they have children, they have families to look after, and they value life. So if that message gets emphasized, they change. And we've had testimonies and stories of those who have abandoned that life. And if when their situation improves, they take on normal livelihoods.
You did talk about the pre-exposure prophylaxis. How continuous is one supposed to use it? Because there's a time years back when people would think like, for as long as they're determined to have unprotected sex, that is what they would use. and just like how you would say that people have become pharmacists themselves or doctors themselves, and they will go and buy off-the-counter drugs, and even those which are not supposed to be off-the-counter as much as they please. So how are you going to manage that? Because given that they know that it's one of the safe ways to go, it might as well become a solution to them.
It's very dangerous for them to think like that. It is like saying, I can stand there and dodge bullets because I have dodged. You can't risk your life like that. First of all, there is what we call the post-exposure prophylaxis. That if you've had accidental exposure, you need to take the pills. The doctors will prescribe for you, and you should take it within 72 hours. And that is usually in the case of rape. And therefore, but you need to do that only if you're HIV negative. Okay, so you need to know your HIV status. Now, for pre-exposure prophylaxis, you don't take it and go to have sex. It won't work. You needed to have taken it, there's a recommended minimum number of days, because it needs to build a certain level within your blood. And then, so, for instance, if maybe you're HIV negative, your spouse is positive, he travels a lot, he will be coming back. So you need to anticipate and plan for that and take the pill continuously. So it's not a luxury. So you can imagine taking medication all the time just because, so it's not as simple as that. And if people think you'll just swallow a tablet, go and have sex, and then go back and stop, it will not work.
Okay. Then coming back to the adolescents on the issue of drug adherence, there are certain times I'm imagining, yes, school is a safe community, but you can imagine a situation when a child is constantly, because they have to take the daily medication. Some schools might be courteous to say that you keep your drugs with the school nurse. So the school nurse works like that person who offers the support system and will always encourage and remind. But there are some of them who possibly choose to do away with the drugs for the period of time they're in school, because they don't want to be identified that way, and they want to also fit into society.
That is true. We've actually, we've been told stories of worse, where children living with HIV are stigmatized by their teachers. If a child is not responding, or is not answering questions for different reasons, not because they are on medication, the teacher will rebuke them. Or we've had incidents where, because it may be time to swallow the drug and they have to leave and go out. So that support system, we are working with the Ministry of Education to ensure that deliberately the school team, management, teachers, somebody is identified, like the senior woman or the school nurse who keeps the medicine, but also these children are deliberately cared for without exposing them and stigmatizing them. It's true that they would want to live like other children, and that's why it's very important to speak to them early, so that they know why they are taking these medicines, that it is important to build their self-confidence as well, to show them people that who have HIV but who are adults, who are living productive lives, and saying that it is not your problem that you have this condition. You got it accidentally, but you can remain alive, you can be productive, you can become a useful adult. Once they have their self-confidence and they know why they are living and they get empowered, They will, you know, stand their ground. They will tell off their friends. They will come out and, you know, speak. But it takes a lot of confidence building. It takes a lot of support from both their parents and their teachers for them to come out like that and deal with the situation.
Of the school programs, I'll just give an example. In terms of skilling, I know it for a fact that now DIT is almost compulsory in most of the secondary schools, so that these kids are able to gain a skill. What is the plan and strategy by government to see to it that sex education is properly engraved among these young children and they know the dangers of some of the things or the adolescents that they are engaging themselves in?
Now, we have a sexuality education framework. It was, you know, prepared. It provides guidance in terms of age-appropriate information. And although it was misunderstood by some of our stakeholders, and they thought that children were going to be taught that when you start talking about sex, you will interest them, they will want to know what this is, and they will end up engaging in sex, which is not true. The reverse is true, that if you keep quiet about it, and they discover it by themselves, then they will move ahead and explore. So there is a framework, a guidance framework, and this is being used by the Ministry of Education. They should draw detailed guidelines for both in school, and the Ministry of Gender will do that for the out of school. But it shows that, you know, for each age group, this is the information that should be shared with them. And of course, the teachers also needs to be empowered, because the teacher should be able to respond to questions once they are raised by the learners, and should come from a position of knowledge for them to authoritatively speak to these issues, address the young people, and so that, you know, the learners can look to them with confidence. So there is a program. It was launched by the Minister of Education, who is also the First Lady, and this is available. There is available guidance on what needs to be done for each age group.
Okay.
Yes.
Then what about the fact that now, with the generation which we are in, we can't run away, the access to gadgets and digital technology? You'll find that some parents are getting the shock of their life to see that they are coming across videos of their children who have posted themselves on TikTok, and the kind of talk that they are communicating out there on TikTok on their accounts is just alarming. How are we going to try as government to see to it that we streamline, possibly, or help guide these young people on whatever you want them to move with the trend? Yes, true, but on how they choose whatever they choose to communicate out there, and also how they select carefully the kind of content they watch on their gadgets.
So again, like you've pointed out, this is an information age. It's true that we need to delay introducing children to gadgets as much as possible, but you can't avoid it forever, because it's a medium of instruction. You know, schools are using it to provide instructions, to give lessons, to share materials. So again, the power lies in sharing with the children, cautioning them, telling them that everything you see on the net, first, is not true. There's a lot of fake news, as they call it, you know, information that is not correct, that, you know, when you're there, you can be abused, you can be bullied, you can be, all invites that pop up are not true. And the problem with the internet is that, one, it's so vast, but two, is that people will come, it's like a black hole. Somebody will come, you know, present an identity that's not true, you know, and probably pose. So cautioning them and guiding them and being present all the time to say, what have you been? But also you can work with the IT experts to make sure that the minimum you know, applications are installed to block, you know, visitation of wrong sites, pornographic sites and others. So it's about guidance, it's about, you know, walking that journey with them. Shutting them out from accessing gadgets and from watching TV is a temporary solution, because these children, you need to equip them so that when they grow and leave our homes and they are out there, they have the skills to protect themselves.
Oh, yes.
Yes.
Oh, wow. So as a ministry, I mean, as Uganda AIDS Commission, with this rise amongst the adolescents, what other strategies and interventions do you have? You talked about some at the beginning, but I don't know now how you really intend to ensure that we're able maybe to stay where it is and the infection rate doesn't go high, especially amongst the girl child, or to see to it that it is lowered.
So we first of all, our role as a commission is coordination to ensure that first we design the policy and strategy, and we've just finished evaluating the current strategy, which runs up 2025, to see where are we as a country.
Okay.
And that's where we realize that the infection rates in these young population groups is not good at all. So we are going to work with the different stakeholders and say, as Interreligious Council of Uganda and the faith-based groups, what can you do for us? We've designed messages and we would like to use platforms for those stakeholders, you know, the Mothers Union, Fathers Union, youth platforms, the youth missions, the Jumas for the Muslim faith. And because they have a specific audience they reach, and they have a very powerful voice that they can use. We're also working with cultural institutions, with the kings, the clan leaders, to make sure that the message, working with the King of Uganda, the Kabaka of Uganda has really been instrumental. He's been consistent. The last 4 years, he's dedicated his message. Recently, he was launching the Vika football. And, you know, we found him, His Majesty the King of Torah as well, you know, young king, followed by a lot of the young people in the population. So the different categories of stakeholders is how we're also working with young people groups, the Uganda National Students Association, to promote those debates. In schools, we have groups of the Uganda network of people living with HIV, young people. They have beauty pageants, largely to fight stigma and discrimination across the country, to show that you can be a young person with HIV but still, you know, live progressively and live a productive life. So Ministry of Education itself, we are working with them to go through schools. So every single ministry, department and agency, but as well as the private sector, the cultural institution, the group that we've reached out but are still yet to exploit fully are the artists, because the artists are very influential. Oh, very, very. They have a lot of following. Very. And would like to work with the artists, you know, to some of them are already, you know, have accepted. People like MC Katz, you know, is one of our ambassadors. He's been putting a message out there, telling young people that, you know, if you don't move properly, this is where you can end up. If you move correctly, your life can be like this. So communication, people like yourselves, you know, people to use your platform to reach out. So one of the things we've done is to design messages targeting specific population groups. And these messages can be used every time, whether you're talking to adolescents, or you're talking to parents, or you're talking, you know, to different categories, very specific messages that are given to them, so that they can use this, you know, to equip themselves and protect themselves as young people as much as possible. Okay. Yeah. So in about a minute, what is your final message to a person watching you right now? My final message is that we have a goal of ending AIDS by 2030. 2030 is less than 7 years away. This is an ambitious, but it's a possible goal. It will take all of us. It will take government, and government is doing its best, but even you as an individual, first make sure you know your HIV status and the status of your partner. Protect yourself, protect your partner, avoid, you know, stigmatizing anybody, whether it is your child or any member of the community. Go and test. If you're HIV negative, stay negative. If you're HIV positive, start on treatment. You'll be productive, you'll be well, and we should be able to achieve the goal of ending AIDS by 2030. Okay, thank you so much, Dr. Nelson, once again, Musoba, for taking time off to be able to share this useful information to the public. Well, that is all we had for you tonight. I'm sure Doctor has put it out all for you. I don't need to ad-lib and add anything more, but stay safe, because trust me, the ABC strategy still works and needs to work. Well, it's just about a few minutes to the top of the hour, like 6 minutes. Rhoda and Gonzi will be coming your way with the 10 o'clock news. Good night from me and from Dr. Nelson. Thank you.